Hi there. Our lesson today is going to revolve around the changes that our body makes during pregnancy. And as always, my standard disclosure is this lecture is probably not suitable for young children. As we're looking at the signs of pregnancy, nowadays as I was saying, now in our current times, if we're wondering if someone is pregnant, we will use either ultrasound or something to visualize a pregnancy. But there are some signs of pregnancy that NCLEX really likes you to know. I don't know that any of these are necessarily being used anymore in our modern society, but those signs are Chadwick sign, Goodell sign, and Hagar sign. And as you can see here, they are all named for the different parts of the body that is changing. So they're named after usually male physicians. Chadwick sign is the changes of color that the cervix starts to make. And Goodell sign is the softening of that cervix, the cervix being the lowest part of the uterus. And the Hagar sign is the softening of the lower uterine segment. So these are real good NCLEX questions, and you may see this sort of thing on NCLEX or ATI. The other signs that we talk about are what we call presumptive, probable, and positive signs. And there's lists of these. They're listed in your book as well. Presumptive signs are subjective. This means that the possible explanation for these changes that are happening is that it could be pregnancy. So for instance, some of those presumptive signs are amenorrhea, not having a period. So we know that there are other conditions that cause you to stop having your menstrual cycle. So it is a presumptive sign of pregnancy. Urinary frequency, again, there's other things that could cause that, so it's presumptive. Nausea, vomiting, breast tenderness, and fatigue. So these are your possible, these could be pointing to a possible pregnancy, but they're not definitive. And then we have more presumptive signs: hyperpigmentation of the skin, fetal movements, quickening, uterine enlargement, and breast enlargement. And these are the weeks that those things happen. You'll see that the breast definitely changes during pregnancy, and so it's still considered presumptive. And then here you see some of the changes that happen to the skin during pregnancy. And this was very popular. These rings were very popular, I don't know, in the last 10 years or so. But typically, if those stay in during the full pregnancy, it will cause quite a bit of scar tissue there as it pushes up against that. And then we move into our probable signs. These are objective. So Braxton Hicks contractions, probable. Positive pregnancy test is a probable. And a lot of people get confused with this one because they think if you have a positive pregnancy test, it must mean for sure that you're pregnant. But there are some conditions that will cause you to have a positive pregnancy test, even in males. And so it is not considered absolute. Abdominal enlargement, ballottement, which is being able to push up on the cervix and feel the heaviness of the cervix. There are those signs again: Goodell sign, Chadwick sign, and Hagar sign. Those are all probable. And then if we get to positive signs, what we're really looking at is our visualization of the fetus, hearing heart tones, or fetal movement felt by someone else, being able to put your hand on the abdomen and feel the baby moving. So these are what we call diagnostic signs. These are positive signs. These are super good to know because you see these on test questions all the time. Just about every standardized test I've ever seen in maternity will talk about our presumptive, probable, and positive pregnancy signs. So the uterus changes. It changes in size, weight, length, width, depth, and volume. There is enhanced uterine contractility. So those Braxton Hicks contractions are really there to to practice using this muscle. Braxton Hicks are the contractions that we call pre-labor or pre-contractions, and actually women start having them as early as 20 weeks. We need to pay close attention to how quickly they're coming together, how often they're happening, because we want to try to avoid preterm delivery. But Braxton Hicks contractions are practice. They're getting that uterus ready. After about 3 months, the uterus will move from being a pelvic organ to an abdominal organ. It pushes everything up and moves up out of the pelvis. And your fundal height at about 20 weeks gestation should reach the level of the umbilicus. So that about halfway through that pregnancy, we should be at the level of the belly button. And that's a pretty reliable determination of gestational age. So if I'm doing a fundal height, it's about the same, the centimeters of the measurement is about the same as the gestational age up until about 36 weeks. And the reason why it changes then is because the baby starts to settle down into the pelvis, getting ready for delivery. And so sometimes you'll actually see them lose a few centimeters. But we do use fundal height to help determine. It's a rough estimate of the approximate gestational age. Obviously, things will change if the woman is obese, if she has gestational diabetes, if there's some condition that's causing the baby to be smaller. So it's not exact, but it's a rough estimate. For those of you that will be working in outside clinics or ERs, it's a quick assessment that you can try to determine how far along someone is. So here's just a picture of what I was just describing, those changes by about the 3rd month. Here, by about the 20th week, they should be at the umbilicus, and then it moves up into the abdomen. So I like to show this picture when I was teaching childbirth education. I like to show this picture to moms and their partners, because they don't understand why they feel so differently. And you can see, as this is a non-pregnant woman, and all of her organs have lots of room. They're where they're supposed to be. And then as you start to grow a baby and it pushes against all the organs in the body, the bladder changes, the spine changes, the bowel changes. Here, your intestines change, your stomach, your liver, your lungs, everything is pushed up out of the way so that this fetus has room to grow. So this is why you see more heartburn. This is why you see shortness of breath. This is why you see more constipation. This is why you see low backache. This is why you see unable to eat large meals. So all the comfort measures that we discuss are based on the physiology of what's happening in the body. So other adaptations that are happening is that cervix changes. It starts to what we call ripen about 4 weeks before birth, where it starts to become softer and thinner. And as we talk more about labor next week, we will discuss the changes that it goes through in a very short amount of time. The vagina starts to change. It's more acidic. There's typically more discharge. Sometimes it can be white and thick, and people are concerned that maybe they have an infection because it's changing so much. I see lots of women coming into the hospital saying, I'm just a little more wet than I normally am down there. What's going on? They're worried that it's their water leaking, but it's part of the process. It changes in order to keep bacteria away and out of the cervix. So the ovaries actually enlarge until about the 12th or 4th week of gestation, and then they stop ovulating. So the hormones from the placenta are telling the body, no more egg production. We've got to worry about growing this one. And then our breasts are going to change in size. So our breasts change in size. They are getting ready for lactation. In fact, they continue their development in lactation. So our breasts are not completely developed. I mean, in pregnancy, or they're not completely developed until we become pregnant. You see a change in nipple size. They change color. The pigmentation changes. And the idea is it becomes darkened, the areola becomes darkened in order for the baby to have kind of a target. They see black and white colors and not so much the vivid colors. so well after birth, and so they're looking for a target. There will be production of colostrum as early as the 12th week. Some women notice it, some women don't. If you don't notice it, it doesn't have any bearing on whether you will be able to produce milk or not. But all breasts go through some changes during pregnancy. And here's an example of some of those changes. So again, just to look at the anatomy of the breast, your nipple is just the conduit to get the milk out. These are those milk sinuses. And then back here is where the milk is actually made. And it has to come down these tubules and be expressed through the nipple. And as pregnancy progresses, these start to develop. So many women do notice breast enlargement during pregnancy. And here's just a really good picture of how things change in the uterus. I know this picture is a little small, but it's a drawn picture versus a real example of how things change. The GI system has a lot of changes to it. We see hypersalivation in a lot of women. Sometimes they're swollen gums. If there's any sort of dental issue, we definitely want mom to get that taken care of early, because we know that gingivitis and some of the other infections that happen in the mouth can actually increase your chance of preterm labor and preterm delivery. There is decreased peristalsis in that smooth muscle. And so we see increased constipation. There's also increased constipation because of the pressure of the baby. We see pressure from the uterus that can cause hemorrhoids. The gastric emptying is slowed down. Heartburn increases. Prolonged gallbladder emptying. Many women, if they're going to have a gallbladder issue, it will pop up during pregnancy. And then, of course, our early nausea and vomiting, and sometimes it happens all the way through the pregnancy. Looking at our cardiovascular system, this is actually very interesting. There's an increase in blood volume to about 50% above pre-pregnant levels. And why does that increase? It's because we're going to be losing a lot after delivery, a good portion. And so there needs to be an increase in blood volume for that purpose. But what doesn't increase is the parts inside the volume, inside the blood. So what we see is a decrease in our iron levels, in our hematocrit and hemoglobin. And so we call that anemia of pregnancy. So a lot of women will say, yeah, I was anemic during pregnancy. That's a normal physiological state. Now, if they were anemic before pregnancy, then we have a problem, because now they're even more anemic. You see increased cardiac output, increased heart rate. There will be a slight decline in blood pressure until about mid-pregnancy, that 20th week or so, and then it should return to pre-pregnancy levels. Women that have cardiac issues before they get pregnant will have increased cardiac issues, typically, with pregnancy. We do see increased number of red blood cells, but that is that volume that I was talking about. So this is what we call physiologic anemia. And so we have an increase in iron demands, and the best place to receive iron is from your food. It is not well absorbed in a pill form, even though we see it in the prenatal vitamins and we encourage women to take extra iron. It's not as well absorbed as it is through food products. Towards the end of pregnancy, women become hypercoagulable, which is makes sense because they are going to need to clot afterwards, but that also puts them at higher risk for blood clots and those conditions. Our respiratory changes, breathing becomes more diaphragmatic, and we have increased oxygen consumption. And you see a lot of women, because of the extra blood volume, they become stuffy in their nose. They say, I don't know why I'm sniffling all the time. And it's part of the physiologic changes that are happening within their body. Renal system changes, we have a dilation of that renal pelvis. These get stretched and pulled, And we have an increase in our GFR, increased urine flow and volume, and that's because the mom is now handling the waste products for the fetus as well. And so there's an increase in kidney activity with women lying down, especially in greater pregnancy. So our poor kidneys go through a lot. If you have one kidney, you definitely have a higher risk during pregnancy and will need to be followed closely by a physician. Then we see our musculoskeletal adaptations. As I mentioned before, that curve, that lordosis of the spine definitely changes. There's a shifting of the center of gravity because before, a woman didn't have anything kind of sticking out here on the front. And now as she is carrying this fetus, it definitely changes her center of gravity. And so their balance can be off. We recommend pregnant women are not climbing ladders and getting up in trees and that sort of thing. And you'd be surprised. Sometimes these women come in after having a fall saying, well, I just thought I'd get up there for a minute and I was trying to hang something in the baby's room. And so we have to really tell them that their center of gravity is off and they may not be aware of that. We see a softening and stretching of those ligaments. That's from that hormone relaxin, and that especially works on the symphysis pubis, but it actually works on all the ligaments. We will see that waddling gait of women as they that relaxin starts to work on their pelvis, and so that's that waddle gait of pregnancy, where you can notice that someone's pregnant from behind. The integumentary system probably goes through some of the biggest changes. Depending on your skin tone before pregnancy, some of these can be pretty pronounced. Hyperpigmentation, that mask of pregnancy, I have some pictures of it coming up, is called melasma, and there's nothing we can do to prevent it from happening, but it usually fades and goes away once the pregnancy is over. We have that line that goes down the abdomen called the linea nigra. We have stria gravidarum, also known as stretch marks, varicosities. If you had varicose veins before you got pregnant, they're definitely going to be more pronounced with the greater blood flow. And some women have varicosities, it runs in families, that are pretty pronounced in their legs, and then they find out that those veins go all the way up through their labia, and they can be pretty significant in the labia, even cause some significant bleeding risks during delivery. We have vascular spiders, palmar erythema, where there's itchiness of the palm or of the skin. And our book talks about a decline in hair growth, and an increase in nail growth. My experience is that women usually talk about their hair feeling very lustrous and healthy during pregnancy. So I'm not so sure about the actual decline in hair growth. I think it's actually an increase. So here's some of those conditions that I was talking about. Here's a good example of melasma. And this, like I said, can be pretty pronounced, and some women are very concerned by this, but it usually goes away fairly quickly after pregnancy. And then these are those varicose veins that can actually travel all the way up. They can be pretty pronounced as well. There's the linea nigra and 2 different skin tones. And these are all caused by hormones. Here is what the stretch marks look like as they're being formed. This is just the abdomen stretching faster than the skin can put down that collagen. So they start off kind of this red, angry look, and then they will fade to this silvery white. These typically do not go away. And there's every product on the market to try to prevent stretch marks. Some people swear by cocoa butter. Some people swear by vitamin E oil. I think none of those things are going to hurt anyone, so they can certainly try. But just like most of the cosmetic industry, I think a lot of it is hype, and not sure that it really makes that big of a difference. The pituitary gland definitely changes. We see enlargement. It's producing lots of hormones to maintain that pregnancy. Eventually, the posterior pituitary is going to increase the oxytocin as the baby matures. Oxytocin is the hormone that is going to work on the uterus and cause contractions. It's also the hormone that is the milk ejection, causes the milk ejection reflex. So as the baby is nursing and the milk needs to come from the back of the breast down into those sinuses. Oxytocin actually is a hormone that does that. So as the pregnancy continues, we see production of natural oxytocin. And Pitocin, the medication that we use in labor, is a synthetic form of that. It is not the same thing, it's synthetic. The pancreas is going to have an insulin resistance. And so if women may develop what we call a gestational diabetes, and this is just during the time of pregnancy that they have a resistance to insulin and can have some blood sugar issues, and we'll talk more about that later. The adrenal glands increase cortisol and aldosterone, which increases inflammation in the body. There's prostaglandin secretion. A lot of the prostaglandins are to maintain the pregnancy, and then eventually those prostaglandins will start working on softening that cervix. And again, our placental secretions, the things we talked about before, human chorionic gonadotropin, that HCG, the hormone that we're looking for in the pregnancy test. We have HPL. We have relaxin, progesterone, and estrogen. So if you look at these tables in your book, you will see all the different hormones that are produced. Nutritional needs, women that are growing a baby need to increase their nutrition and specific things. And there is the need for vitamin and mineral supplements, because in our modern society, we just don't see all of these minerals in the food, especially in the mass-produced vegetables and things that we see. They just don't have the same nutrients that they had 100 years ago. So we want to see an increase in protein, iron, folate, and calories. Folate is the vitamin that reduces our neural tube defects. And I know you've heard the term folic acid, but folate is what our body uses, gains from food, and then changes it in the body to produce folic acid. So one of the things we have seen, this is some evidence-based practice, is there's some idea. We've had a lot we've had a large increase of babies being born with something called a tongue tie. And so this is where the piece of tissue that's underneath the tongue becomes very thickened and hardened and keeps the tongue from moving appropriately. And we see these babies sometimes have issues with breastfeeding, even removing milk with a bottle. They will have sometimes issues with swallowing, and then later in life they could have speech impediments and dentation issues, and even the development of sleep apnea from their tongue being in the malposition. So what the research is kind of pointing to is when we started increasing everyone's folic acid in an effort to decrease the neural tube defects, that is encouraging the growth of this piece of tissue underneath the tongue and causing these tongue ties. So it's kind of interesting, the thing that we have pushed in our society to try to solve one problem is now potentially causing another issue. So the USDA has come up with a food guide, the MyPlate food guide, and then there's My Pregnancy Plate, and they have issued a warning about some specific fish due to the mercury content. So there are some certain food items that should be avoided. So here's an example of My Pregnancy Plate. It looks very similar to the MyPlate idea. And basically what they're saying is half of the plate should be non-starchy vegetables and fruit. That's okay. Those are foods. You can get a lot of what you need from these. Unfortunately, in our world, we don't see a lot of these foods eaten. Swiss chard, beets, Brussels sprouts, they're not always on everyone's plate, but they should be. And then here we want protein, and those protein sources can come from nuts and beans and seeds. They don't have to be from animals. And then whole grains, legumes, and starchy vegetables should be another third over here. We want to increase our vitamin intake. And again, the best way to increase our vitamin intake, along with the supplement, is to be looking at foods from every color, the vegetables, fruits from all different colors. Maternal weight gain is going to be based on the BMI before pregnancy. So if you have a BMI less than 19, which is considered underweight, we're going to want this mom to gain somewhere between 28 and 40 pounds. If the BMI is less than 25, so normal weight, we want this mom, I'm sorry, if the BMI is greater than 25, which is overweight, we want that weight gain to be somewhere between 15 and 25 pounds. And then if she's at a healthy BMI, 25 to 35 pounds is what we should be expecting. So any BMI between 20 and 25 is our healthy BMI. And so we are looking for weight gain based on the mom's BMI. And these are numbers that you should probably have in your head, because these come up in test questions all the time, both mine and NCLEX and ATI. So looking at the food pyramid, the food guide, it's not the pyramid anymore, it's the MyPlate. We also have to think about our different variations. So there are some cultures that don't eat meat at all. There are some cultures that have a large variety of grains, and so we want to make sure that they're getting the whole grains, not just the processed grains. Some people are lactose intolerant. That's perfectly okay. There's lots of other ways to get a milk-like substance that has vitamins in there. There's milk from everything you can imagine now, plants like soy, nuts. So there's lots of different ways that we can get those foods. I think the key is making sure that they're eating a large variety of things. As I said, vegetarianism or veganism, you can grow a healthy baby. The body is set up that if mom is not getting everything that is necessary, the body will actually shunt it from the mother to the baby. So as long as we're getting some nutrients in there, the baby will get everything they need. Unfortunately, then the mom's body suffers. And that's especially important in our younger teens that are still developing themselves, and our older moms. And then we have something called pica. Pica is the condition of eating non-food substances. And some women have such intense cravings during pregnancy. They crave things like clay, ice, dirt, laundry detergent, all kinds of things that are very odd, and they'll be very embarrassed to talk about these things. Usually it means that they're not getting what they need in their diet. So if someone does share with you that they're eating something strange, an unusual, a non-food item, we need to really look at their diet to see what it is that we could increase. Usually iron is a big one. Especially those that are looking for ice and that sort of thing. So we just need, in our non-judgmental tone, this is a common occurrence during pregnancy. If you're having extreme cravings, it probably means that we're missing something in your diet. Maybe look at changing the vitamin to get what they need there, and making sure that we're being safe in the things that we are eating. In our environment, eating dirt could be a significant issue because we have valley fever. And they could be eating, even ingesting valley fever spores. So we have to be very careful. So here are some of the different types of pica, and it can get very odd, as I said. And then we look at our maternal emotions during pregnancy. These things change you hear the jokes about the mood swings during pregnancy, but it's based on all those hormones that we're not used to having, those large levels of hormones. So we see things like ambivalence to the pregnancy, it being more introverted, and then they'll move into an acceptance about this baby to come. Changes in body image definitely can affect how a woman feels, especially if that's very important to her psyche to begin with. And so as her body starts to change, in our society, we value thinness. And if that is, significantly changing as that baby is developing, that can change how a woman is feeling. And that can move into her pregnancy, her sexuality. There are lots of changes going on in her body, different things that are feeling uncomfortable, that are pushing, pulling, and this may start to affect her sexual relationship. Sexual desire usually changes with each trimester as they move from the first trimester and all the changes in the body, and sometimes that nausea, vomiting, into the second trimester. Women sometimes say that's the best trimester for sexual activity. Women can continue having sex until they are not comfortable with it anymore, or if there's any sort of high risk pregnancy, they need to talk to their doctor about continuing their sexual activity. If you're at risk for preterm delivery, we certainly don't want to be having sex. And if there's any sort of placental issues or bleeding issues, that there needs to be no sexual activity so as not to cause that, not to make that condition any worse. The partner's going to be changing depending on how involved they are. If it was a wanted pregnancy, they may be very excited. You'll hear things like, we're pregnant and we're having this experience. And it's different. We've gone from in the 1950s where no one really even talked about pregnancy and men certainly weren't invited into the delivery room, now to sharing the pregnancy with the partner. Something called Puvade syndrome, sympathetic pregnancy, where the partner starts to have cravings, the partner starts to have nausea, vomiting, and maybe even some weight gain. It's an interesting phenomenon. Usually their partner's reaction changes as the pregnancy changes, in that when there's not a lot of outward signs, it's really hard to grasp the reality of what's going on. And as the baby starts to grow and they can feel the baby from the outside, they start to feel more involved in the role. And you really see it hit these partners when the baby's born. If you want to have a good cry in a delivery room, instead of watching the mom during delivery, turn and watch the partner. That you can see it on their face that it's really just hit them. And then helping them to prepare for their role in co-parenting this baby, especially if the woman is breastfeeding. We need to help them find their specific role and how they're going to be bonding and helping this baby once it's born. And then, of course, if they're siblings, they will be changing their roles as well. There are lots of preparation available to these kids. They need to, if they're going to be in the delivery room, they certainly need to have seen a delivery on video, some version of it, before they see their mother go through this, but helping them to adjust to their new role. And then you have the grandparent role. That's something that's not talked about a lot, but grandparents have a completely different role than parents. And as that's the stage of life that I happen to be in, it's definitely a role change, and a good one. My experience has been extremely good, but it's a role change. And as we go throughout our lives, we are going to see changes in our roles. And so as nurses, we just need to be willing to accept that all of these changes are happening, and trying to facilitate what we can on our end to help with this changes. So that's the end of this lecture. And if you have any questions, you know how to reach me.